Welcome to the Deep Dive. You're here because you want to get the crucial information on important topics quickly and thoroughly without getting bogged down in endless details.
Exactly.
Today we're diving into something really vital. The nice guidelines on epilepsies in children, young people, and adults. This is quite a comprehensive set of recommendations recently updated January 2025.
Right.
And our goal really is to pull out the key insights about how suspected epilepsy is initially addressed. You know, the diagnosis, the assessment, those first crucial steps.
Yeah, exactly. For anyone facing a potential epilepsy diagnosis, maybe for themselves, maybe for someone they care about, these guidelines are, well, they're the go-to resource. But let's be honest, wading through a big document like that, it can feel a bit much.
Definitely.
So our mission today is to give you that essential understanding of what happens right when epilepsy is first suspected.
Okay, so let's start right there at the beginning. Someone has what seems like a first seizure. What's the immediate action? What do the guidelines say?
They're very clear on this. An urgent referral is recommended.
Urgent, meaning?
Meaning an appointment should be set up within 2 weeks. For adults, this needs to be with a clinician who really knows their stuff when it comes to assessing initial seizures and diagnosing epilepsy.
Okay, specialist.
Yes. And for children and young people, the referral should be to a pediatrician who also has that specific expertise.
That 2-week window, it really jumps out. Why is that time frame so critical, do you think?
Well, the urgency really comes from the evidence suggesting that intervening earlier, getting that assessment done quickly, can significantly cut down the time it takes to get seizures under control.
Oh, okay.
And ultimately, that can improve the person's long-term quality of life. It's kind of like getting a head start on managing it effectively.
Makes sense.
And the guidelines also point out another situation where this 2-week urgent referral kicks in.
Yeah.
If someone has a seizure again after they've been seizure-free for a while.
Right, or recurrence. You'd want to get back into specialist care quickly then, too. Okay, so after that first suspected seizure, what about the assessment itself? I imagine it's not just ticking boxes.
No, absolutely not. The guidelines really emphasize a personalized approach, especially when assessing the risk of having another seizure.
Personalized how?
Well, for adults, for instance, it includes specifically looking for what they call modifiable factors.
Modifiable factors, like things you can change.
Exactly. Things that might be contributing to the seizure that could potentially be addressed. So think about underlying mental health stuff like depression or anxiety, maybe vascular risk factors, high blood pressure, diabetes, or even an infection like sepsis.
Right, things that aren't necessarily permanent fixed conditions.
Right.
What about for children? Is a risk assessment different after a first seizure?
It is, yeah, and there are some interesting points here. The guidelines note that a febrile seizure, that's one happening without a fever, actually brings a higher chance of having more febrile seizures later on. Yeah, especially within the first, say, 6 to 12 months. That's compared to a first seizure that happens with a fever.
Huh. That's actually kind of counterintuitive, isn't it? You almost expect the fever seizure to be more concerning long-term.
It might seem that way. And what's also really key is that not all febrile seizures are the same. The guidelines mention complicated febrile seizures,
Complicated.
meaning ones that last longer, maybe over 10 minutes, or have other features like weakness on one side afterwards. These might suggest a slightly higher risk of developing epilepsy later, particularly if other predisposing factors are already there.
Okay, so it's not just if there's a fever, but the actual characteristics of the seizure itself that provide clues.
Precisely. And across the board, for all ages, the guidelines push for a person-centered discussion,
Right.
really talking it through with the individual and their family or carers where that's appropriate about their specific risks. And this isn't just medical stuff, but also, mental, physical, social factors that might be involved and how some of those modifiable factors we mentioned might be tackled.
That sounds like a really thorough, thoughtful approach. Beyond figuring out the risks, what about immediate information? What support should people get right after that first seizure?
Oh, practical info is absolutely key then. The guidelines say provide clear, easy to understand details on how to recognize if another seizure might be coming.
That could be crucial.
Yeah, for taking action early. And they also stress providing first aid advice and initial safety guidance. Basically, what do you do in those critical moments if another one happens?
That's foundational knowledge, yeah. That can make a huge difference. Okay, so we've got the urgent referral, the initial risk assessment and info. What's next? The specialist assessment, getting to a diagnosis.
Right, the specialist assessment. This is where they really dig deeper into the person's medical history. And it's not just a quick chat, it should be a detailed account of exactly what happened.
Mm.
The guidelines specifically mention how valuable eyewitness accounts can be, and even looking at video footage of the seizure if someone managed to record it.
Video footage? Yeah, people might not think of that, but I can see how incredibly helpful that would be for the specialist.
Oh, absolutely. It's like detective work, isn't it?
Yeah.
Piecing together clues from the event itself, it can often help tell the difference between an epileptic seizure and other things that might look similar sometimes, like fainting or certain movement issues.
Right, mimics.
Exactly. The guidelines also recommend a 12-lead ECG.
The heart trace.
Yep, electrocardiogram. That's to help rule out any heart-related conditions that can sometimes present like seizures.
Interesting. So part of this is ruling out other causes.
Precisely. And the guidelines also remind us that metabolic issues like hypoglycemia, low blood sugar can also trigger seizures. So that's another thing to check.
Okay.
And then, depending on what the history and examination suggests, we start thinking about neuroimaging brain scans, especially if there's a suspicion of an underlying structural problem in the brain.
What kind of things might make a specialist suspect a structural cause?
Well, maybe a history of a significant head injury. Or if they find focal neurological signs during the exam, like weakness down one side, or maybe specific patterns in how the seizure itself was described, those could raise suspicion.
Got it. And then you mentioned neuroimaging,
Hmm.
but also the EEG, right? That's the brainwave test everyone thinks of with epilepsy.
Yes, the EEG, electroencephalogram. It's important to understand its specific role here. The guidelines recommend considering a routine EEG, usually done while the person's awake.
To help confirm things.
To help support the diagnosis, yes, if the history and exam already strongly point towards epilepsy, and the EEG can give really useful clues about the seizure type or maybe even the specific epilepsy syndrome.
So helpful, but it's not the definitive answer on its own.
Exactly, and this is a really critical point they emphasize. An EEG should not be used to rule out epilepsy.
Right.
A normal EEG doesn't mean someone definitely doesn't have epilepsy.
That's crucial to understand.
Very. Ideally, if an EEG is needed after a first seizure, they say try to get it done quickly within 72 hours if possible.
Wow. That's a tight turnaround. Why so soon?
The thinking is the EEG might be more likely to pick up any temporary abnormal electrical activity in the brain if it's done closer to the time the seizure actually happened.
Okay. Makes sense.
The guidelines also talk about provoking maneuvers during the EEG.
Right.
Things like hyperventilation, getting someone to breathe deeply and quickly, or photic stimulation. That's the flashing light test you sometimes hear about.
Ah, the flashing light. I imagine that needs careful discussion.
You're absolutely right. The guidelines specifically stress talking through the potential benefits, but also any risks or discomfort with the person and their family before doing them.
Good.
If everyone's okay with it, these can be part of the routine EEG because they can sometimes trigger those telltale brainwave patterns in people prone to seizures.
And what if that routine EEG comes back normal, but the doctor's still unsure?
Good question. If the routine EEG is normal, but there's still diagnostic uncertainty, the guidelines suggest considering a sleep-deprived EEG.
Making someone tired first.
Basically, yes. The idea is that the changes in brain activity during sleep or when tired can sometimes unmask abnormalities that aren't obvious when someone's wide awake.
Interesting.
And if both the routine and sleep-deprived EEGs are normal, and there's still uncertainty, then ambulatory EEG is an option.
Ambulatory.
Yeah, that involves wearing a small portable EEG recorder, usually for up to 48 hours, recording brain activity over a longer period during normal daily life.
So a real step-by-step approach to EEG testing, trying to catch those brain signals.
Exactly. Now, let's circle back to neuroimaging specifically. We mentioned brain scans earlier for suspected structural causes.
Right.
The guidelines are very clear. MRI, magnetic resonance imaging, is the preferred test here.
Preferred over, say, a CT scan. Why is that?
MRI just gives much more detailed pictures of the brain's structure compared to CT, and that detail is really crucial for spotting subtle abnormalities that might be causing the seizures, things a CT could easily miss.
Okay, better detail.
Yeah. And the guidelines recommend getting this MRI done, ideally within 6 weeks of that specialist referral. And it should follow specific epilepsy MRI protocols.
Protocols.
Yeah, specific ways of doing the scans, certain sequences designed to be best at finding the kinds of abnormalities often linked to epilepsy. These are usually agreed regionally.
6 weeks seems pretty reasonable for getting that level of detail. What if someone just can't have an MRI? Like if they have certain metal implants?
Good point. If MRI is contraindicated, there's a specific reason they can't have one, then a CT scan is seen as an acceptable alternative. That's for children, young people, and adults being checked for epilepsy.
Okay, CT is a backup.
And just like with those EEG maneuvers, the guidelines mention discussing the risks and benefits of the scans too, especially if someone might need sedation or even general anesthesia to lie still for it.
Right, always important. And who reads these scans? Does that matter?
Hugely. The guidelines are very specific. MRI scans for epilepsy should be reviewed and reported by a radiologist with special expertise in neuroradiology.
A brain imaging specialist.
Exactly, whether for kids or adults. And get this. If someone keeps having seizures even with treatment and the diagnosis is still a bit murky, they even suggest thinking about getting a second opinion on the MRI scans from a specialist at a tertiary epilepsy center.
Wow, like a super specialist center.
Yeah, a highly specialized service. So getting expert eyes on those images is really, really emphasized.
Making sure the right people are looking is key. What about needing another scan later on? Does that happen?
Yes, they outline a few situations where a repeat MRI might be considered.
Such as?
Well, if the first scan wasn't great quality, maybe technically suboptimal, or if the person's epilepsy changes somehow, develops new features, or for certain epilepsy types like idiopathic generalized epilepsy or that self-limited epilepsy with centrotemporal spikes, if they aren't responding to the first-line treatment as expected.
Okay.
And, maybe most importantly, if epilepsy surgery is being considered, then you almost always need updated, highly detailed imaging.
That makes total sense. You'd need the absolute latest picture before considering surgery. What about the emergency room? Someone with known epilepsy comes in after a typical seizure for them. Do they automatically get a CT?
Generally, no. In that specific situation, established epilepsy, typical seizure, the guidelines advise against routine CT scans unless there's something else worrying going on, some new symptom beyond their usual seizure pattern.
Okay, so not automatic. That clarifies the imaging pathway. Now let's shift gears a bit to something really interesting and, well, increasingly important. Genetic and antibody testing. What do the guidelines say here?
Yeah, this is definitely an evolving area. The guidelines suggest talking with a neurologist or a clinical geneticist if there's uncertainty about whether genetic testing would actually be helpful or which specific tests might be best.
So, a specialist conversation first.
Definitely. And they point to the NHS National Genomic Test Directory as a resource for what tests are available.
Right, so it's not standard for everyone, but considered case by case with expert input.
Precisely. And before any genetic testing happens, they really stress the importance of a proper discussion
About
the purpose of the test, what the results might mean, not just for the person, but potentially for their family too. And crucially, getting informed consent. That should involve proper genetic counseling to help understand it all.
That seems vital, given how much information genetic tests can uncover. When do they specifically suggest considering whole genome sequencing? That's the really comprehensive one, right?
It is. Whole genome sequencing is suggested as something to think about for people with epilepsy where the cause isn't known, especially in a few specific situations.
Like when?
A key one is if the epilepsy started really early, like under 2 years old. Another is if the clinical picture strongly suggests a specific genetic epilepsy syndrome, maybe like Dravet syndrome.
Okay.
It's also considered if there are other things going on, like a learning disability, autism spectrum disorder, maybe a structural difference like dysmorphism or unexplained cognitive decline.
So other clues pointing towards a genetic link.
Yes. And for epilepsy starting between 2 and 3 years old, again with an unknown cause, whole genome sequencing might be considered if a specialist multidisciplinary team agrees it's appropriate.
Right, so targeted towards early onset or complex cases.
Yeah.
What about antibody testing? When does that fit in?
The guidelines suggest considering antibody testing again in discussion with a neurologist for people with new onset epilepsy if there's a reason to suspect autoimmune encephalitis.
Autoimmune encephalitis.
Yes, basically where the body's immune system mistakenly attacks the brain, which can sometimes trigger seizures.
Okay, so again, not routine, but considered if the clinical picture fits that possibility. Right, we've covered a huge amount on diagnosis and assessment. Let's pivot now to what happens after a first seizure, focusing on ongoing information and support.
Yeah, this is such a vital part of care. The guidelines really hammer home that information and support need to be tailored.
Tailored to the individual.
Exactly, meeting their specific needs and circumstances. And this absolutely includes making sure children and young people are actively involved in talks, with info presented in a way they can understand, age appropriately.
That tailored approach seems like a real theme running through all of this.
It really is. And they also specifically mention thinking about the unique needs of, say, older people, or those with learning disabilities, or other complex health needs.
How so?
Well, maybe allowing for longer appointments, providing information in different formats, easy read, audio maybe, and involving family, parers, or advocates if the person wants them there.
Makes sense.
They also stress giving people details of local and national epilepsy support groups. Connecting with others who get it can be incredibly helpful.
Absolutely. Peer support is so valuable.
Yeah.
What are the key things that should be discussed in that initial appointment to help someone with self-management going forward?
Several critical areas are highlighted. One is trying to identify potential seizure triggers for that specific person.
Things that might set off a seizure.
Yes. Another big one is talking through epilepsy medications, why taking them as prescribed is so important, and being aware of possible side effects.
Okay.
Reducing epilepsy-related risks is also vital. That includes discussing SUDEP, sudden unexpected death in epilepsy. It's rare, but devastating, so talking about strategies to minimize risk is key.
Right. That's a difficult but necessary conversation.
It is. Then there's the impact on daily life, including really practical stuff like driving regulations.
Yeah, that's a big one for many people.
Definitely. And finally, just taking the time to explain their specific epilepsy syndrome or the types of seizures they have can really empower the person to understand their condition better. And they recommend giving the person a written copy of their care plan, too.
Wow, it's a lot to cover in an initial appointment. But it sounds like it lays a really crucial foundation for them moving forward.
It really does. And it just highlights that managing epilepsy is an ongoing thing. It's not just about getting the diagnosis right. It's about that continuous, comprehensive support and giving people the knowledge and tools they need.
So just to quickly recap then, suspected first seizure means, ideally, urgent referral within 2 weeks to a specialist. Then a thorough, individualized assessment history, maybe ECG, EEG, probably MRI if needed, genetic or antibody tests in specific cases.
Right.
And threaded through all that is providing tailored information, education, and connecting people to support.
That's a great summary. It really is about getting the right experts involved quickly, investigating properly to understand the causes and risks for that person, and then empowering them with knowledge and support for the journey ahead.
This has been a really insightful deep dive into those initial steps based on the nice guidelines. It's clear that acting fast, assessing thoroughly, and really centering the person in the information and support process are the big takeaways.
Absolutely. And it's worth remembering, while these guidelines give a fantastic framework, everyone's experience with epilepsy is unique. Their specific path will keep evolving with further checks and ongoing management.
So, for you listening, what stood out most from our chat today? How might this info connect with your own interest or, maybe, your preparedness in understanding this condition?
Yeah, and building on this, this understanding of how epilepsy is initially tackled, it does make you wonder, doesn't it? Given all the progress we've seen, which these guidelines reflect, what further innovations do you think might have the biggest impact on managing epilepsy in the future? Definitely something to mull over.